Biola, I can hear you guys. Can you guys see me? Can you guys hear me? Can everybody hear me? Oh, okay. Oh, sorry. All right. So I'm sorry, guys. This is our first time, so try and bear with us. Welcome everyone to this session of the Joy IMG to IMG's support forum. And bear with us for the delay. It's our first time piloting this live stream on YouTube. So please bear with us. Okay, I'm going to go straight away. We have a very wonderful speaker with us today. And I'm going to be reading her bio right quick, and then I'll bring her up stage. So today we have our speaker who earned her medical degree from the University of Nigeria. She's a top graduate. She completed her internship at the University Teaching Hospital. She worked as a clinician and later joined the faculty of alma mater as a physiology lecturer. There, she promoted academic excellence and conducted impactful research with leading health professionals, publishing in high-impact journals. Her pursuit of excellence led her to the University of Manitoba in Canada, where she earned a master's in physiology and pathophysiology with a 4.5 GPA and 9 prestigious awards. While in Canada, she demonstrated leadership as a graduate student representative, served twice as a judge for medical student research symposia, and worked as a Canadian Red Cross safety responder, among other engagements. She completed the USMLE and marched into the medicine residency program at Montefiore Hospital in New York. Her projects earned her an honorable mention and prize award at Montefiore's Department of Medicine Symposium. As a passionate advocate for holistic, patient-centered care, she has been featured in the media promoting patient autonomy in medical decision-making. She actively educates communities on advanced care planning and has pioneered communication skills training for fellow residents to improve patient-provider interactions and care quality of care. She has also presented at conferences, advocated for quality of life preservation in serious illnesses. Her scholarly contributions, including serving as a peer reviewer for journals and her widely cited publications on healthcare-related quality of life, have advanced global discourse in supportive medicine. She is a mother of 2 and enjoys spending quality time with her family. Please join me to welcome Dr. Chioma Victoria Nwachukwu, a senior resident who is committed to improving care systems worldwide through clinical innovation, research, and collaboration with global experts. As she takes us through the topic, charting your course, insights on supportive medicine, and navigating the match with flexibility. Ladies and gentlemen, I bring on stage Dr. Chioma Victoria Nwachukwu.
Hi, everyone. Thank you, Tola, for that very extensive introduction. I really do appreciate it. And it's a privilege to be here, not just to speak to this very special community, but also it's our very first live session on YouTube. So I consider it a huge privilege. I'm very happy to be here. Thank you, Tola.
You're welcome. We're excited. Again, it's our pilot streaming, so please bear with us. Hopefully nothing goes wrong.
Yeah, fingers crossed.
So you want to share your screen and I'm going to put it up.
Oh, sure. Should be this one. Do you see my screen?
All right, let the show begin. Can you please give me can you please put in the comment section if you guys can see our screen? YouTube audience, give me a like, give me a response on the comment section if you can see Dr. Nwachukwu's screen. Awesome. All right, go for it. Showtime.
Okay.
They can see your screen.
Here. Okay, there we go. All right. So today's session would be in, two parts. The first would be I would like to talk about supportive medicine, and then we can delve into March and how to approach March with flexibility. And I'm particularly happy to talk about supportive medicine. One is because I'm always happy to talk about it. And secondly, I feel it's very important for this community. I mean, this is an international medical graduate community. And I feel this aspect of medicine it's not so much, out there, but it's so important that we should know about it. Even here in North America, it's still like a field that is still gradually gaining ground, but really it is something that is always there and should always be there and should always be at the back of our minds as clinicians. It's a field that cuts across all specialties. It's a field that can be applied to all specialties. So I want to share it with you for you to have an idea what it's about, so that even as you navigate your medical journey as a primary care physician, as a cardiologist, as a gastroenterologist, these are things that we should keep in mind because they are hardly taught in medical schools and they're hardly taught in any, you know, um, educational organization or institution, so to say. But it's very important. So, what is supportive medicine? It is another name for it is palliative medicine, which is probably the more common or popular name that you would hear about. But many programs right now in the United States, in Canada, they're kind of shifting away from calling it palliative medicine because of the misconceptions that surround that word palliative. Palliative, you would think it's like relaxed, you're not really doing anything, it feels like it's hands off, but that's not what it is. It is supportive care, it is holistic care, it is patient-centered care. It is a field that deals with patient-centered care that addresses several aspects of the human being as a person. It's an aspect that doesn't just talk about the physical symptoms of disease that an individual is facing, but it looks at the person as a whole being. It talks about the spiritual component, it talks about the psychological, the social components of a human being. So supportive care is that field that delivers patient-centered care for individuals and their families, those facing serious illnesses or chronic illnesses at every stage of the disease trajectory. So, palliative or supportive care is concerned not only about the patient in question, the focus is also on the family because no one really should face a serious illness without adequate support of the family, without adequate support of the healthcare system. So, who needs palliative care? All patients at every stage of serious illness. And when we say serious illness, you might be thinking, oh, could it be terminal illness? No, it's not terminal. It does not have to be terminal. When we talk of serious illnesses, we're thinking of chronic illnesses, heart failure, complicated diabetes, chronic obstructive pulmonary diseases, COPD, pulmonary fibrosis, stroke. These are some diseases that Parkinson's disease, these are some diseases that are considered chronic. So it's not entirely curable. It's something that continues and managed based on medications, okay? But the medications only take care of the physical components of that disease. What about the other aspects? It's not uncommon for us to see, patients going through serious illnesses and they're suffering from, they have social issues, they have psychological distress to contend with, they have even their spiritual being distressed. They have something we call existential distress because of the illness. And that is where palliative care comes in. That is where supportive medicine comes in. It takes care of that individual as a whole. And that really is what medicine should be all about. And we talk about all stages of illness because a good number of times there's this misconception that palliative care deals with end of life, or they come in only towards the end of the disease, when the disease is terminal and there's nothing that can be done. Not true. And the earlier palliative care is integrated in the management of a patient with a chronic disease, the better the quality of life for that patient. Because most of these chronic diseases are not curable. You cannot cure them. Example, neurodegenerative diseases like Parkinson's disease, or someone who has suffered from a stroke and is now disabled to some extent. These are things that are not necessarily curable. But what you can do as a physician is to improve the quality of life of that person for as long as the person lives. So the goal is to initiate this kind of care to help not only the patients, but their families to maintain the best possible quality of life for as long as possible. And then you would ask, oh, so who is on this team? Usually the palliative care team is headed by the palliative care physician. So it's a specialty that someone can go into after residency training. And guess what? It's a 1-year specialty. So it's quick, but then because it's quick, the training, I believe, is dense. And then you get to learn a lot of things within that 1 year. Having spoken to fellows and palliative care physicians, they tell me about how, there's a lot of training within that 1 year. It's a 1-year period, but you get to learn a lot of things that you would actually not learn from anywhere else. So the palliative care team comprises the physician, the nurses, the social workers, the chaplains, or spiritual care providers. And, from where I come from, when we hear chaplains, we're thinking of, the church, and we're thinking of Christianity. But these chaplains are specially trained, not to focus on any particular religion, but to focus on the patient's spirituality, what the patient actually believes in, and to help them cope during that serious illness, to bring them comfort, to bring them peace of mind, to address any spiritual distress or any existential distress that they might be facing while navigating serious illnesses. The pharmacists are there mainly to help with medications. So I didn't really talk about the physicians, besides saying that they lead the team. But essentially what they do is they take care of the symptoms that a patient might be presenting with. Let's take, for example, let's just use the very common serious illness, cancer, for example. A patient comes in with cancer, maybe multiple myeloma or any cancer that is causing them some kind of pain. And this patient is still undergoing treatment. It's not like they are not undergoing cancer treatment. They are undergoing treatment, but they're having a lot of pain because of maybe bone metastasis, for example. Now, the palliative care physician comes in. What they do is to assess their level of pain, assess where exactly they're having the pain, assess any other factors that might be contributing to pain. Because it was interesting for me to find out that pain is not just physical. Like most times we just think of physical pain. There are other contributors to pain. Your anxiety can cause you pain. You know, being not being focused, being distressed about something might be compounding to the physical pain that the patient is actually having. So it's the job of the palliative care physician to put these things together and to find out exactly what is causing this patient's pain and how to address the pain. They use several medications, opioids, NSAIDs, Tylenol, to address pain in these patients. Now, the nurses are there to help administer the prescribed medications, but they also are there to watch out for, some other symptoms like delirium, acute confusion, agitation. These are the things that can come up in patients with serious illnesses. Why? Because there is that psychological component to undergoing very serious illness. Now, the social workers are there to provide additional layer of support. What they do is they help address any patient caregiver complexity that might come in serious illnesses. They help with care transition. For example, when the patient is moving from the hospital to maybe a nursing home or maybe to a hospice facility, they also help to deal with that care transition to ease distress for the patient and the family. And then the chaplains, which I just talked about, they're there to help with existential distress that might come with chronic illnesses. The pharmacists collaborate with the physicians to, do things like medication reconciliation. They try to review the medications that these patients are taking. They try to figure out whether there are drug-drug interactions. They try to work with the physicians to increase the benefits of certain medications while reducing the adverse effects of these medications. So everything is targeted towards improving the quality of life of this patient. No one wants to be in pain. No one wants to feel short of breath. For example, a patient with pulmonary fibrosis or lung problems, or patient with heart failure that's having trouble breathing and is not functioning as much as they should. So palliative care team, they come together, and the main goal is to improve the quality of life of these patients, whether or not the disease is curable, whether or not the patient is still undergoing active treatment for the disease. They're there to improve the quality of life, not only for the patients, but also for their families. Other specialists like the respiratory therapists, these ones come in when you're thinking of breathing problems. Music therapists, I was happy to encounter these music therapists during one of my elective rotations, and it was really nice. Like, they come to speak to the patient, and then they tell the patient, oh, what kind of music do you like, what instrument do you like, what can we play you? And it just gives them some comfort. It just makes them feel like they are humans. It just takes their mind away from the disease and just makes them feel human. And then when it comes to complex decision making, that's where the ethicists come in. So it is a continuum of care. What exactly do they do? I'm just going to summarize some of the things that palliative care does. So they help with decision making. And this is something that I didn't really see as a medical student back home. I would say that our culture is more like the doctor makes the decision for the patient. Learning about palliative care and coming over here, I got to understand that it should be a shared decision making. Everyone should have a say in making decisions concerning their health. It is my health at the end of the day. Yes, the doctor is trying to help me. Yes, the doctor has the knowledge, but I should be part of that decision making. So palliative care comes in and they help the patients and the families make certain difficult medical decisions. Because sometimes, especially patients facing serious illnesses, there's a lot of complexity with decision making, especially when you're thinking of, okay, what happens next? Okay, so this illness is not curable. Okay, so what next? What is there for me in the future? What could go wrong? What could go right? How long do I have? Things like that. Oh, would I want to be sustained by machines at some point? Would I want to undergo aggressive medical treatment at some point? Or is it something that is not in keeping with my values, is not in keeping with my goal, is not something that aligns with my preferences? So palliative care helps patients make these decisions. They collaborate with the primary care physicians or the primary doctors that are in charge of the patient care. They try to understand the disease prognostication, and then they try to speak to the patients. One exciting thing about palliative or supportive medicine is that it is a specialty where you're able to sit and talk to the patient. When you start your residency, especially, I will talk about internal medicine because I am in internal medicine. It is like this. You're always on the go. It is very fast paced. You have a bunch of things to do within very limited time. You have a lot of patients to see. So you're just on the go. And hardly do we have time to know our patients on personal level. Now, that is something that palliative care does. It tries to understand and know the patient on a personal level, not only worried about the disease they're facing, but also worried about their families, worried about what matters to them, worried about their priorities. So they help manage symptoms, which we already talked about. Symptoms can be anywhere from pain to trouble breathing to fatigue to loss of independence to vomiting. It can be any of that. So palliative care gives medications and also non-pharmacological interventions to help these patients and their families navigate the course of the illness. Family support cannot be overemphasized. And one point I want you to understand about palliative medicine is that it does not stop the treatment from going on. It is just an additional layer of support. I don't want us to go thinking that palliative medicine is end of life medicine, it's hospice medicine, or nothing else can be done. No, it is an additional layer of support while active treatment is still ongoing. And if in the event death is anticipated, the patient and the family are given the opportunity to prepare for it and explore options for hospice. No one likes to talk about death. I don't like to talk about death. You don't like to hear about death, but it's something that is inevitable. And when someone is facing a chronic or a serious illness, it's time based. You know, you can say you have days to weeks, weeks to months, months to years. And then the palliative care comes in and helps the patient and the families first to process that grief, to process that information, because it's very distressing. It helps them to navigate through the information they've been given, and then it prepares them and gives them opportunity to do what they love to do for the time that they have. And at the same time, try to maintain a high quality of life for the period that they have. So again, palliative care is not hospice and it's not end of life. It is a comprehensive approach to managing serious illnesses with the focus of improving quality of life for not only the patients, but also their caregivers. And I think with that, I'll have to wrap up. I mean, I get very excited talking about it. I can go on and on to talk about it, but I think we should move right into navigating the match with flexibility. And I don't know if I should pause at this point for questions or whether I should continue with the second part and then we can take the questions at the end.
I think, let me see. If you have any questions so far, audience, please put it in the. If you want to ask a question and you want me to bring you on stage to show your face while you're asking your question, put it in the YouTube comment section, and then I can. But bear in mind the people that can. Let me add Dr. Joy to the stage. Okay, Dr. Joy, you're on stage. Please go ahead.
Yeah, thank you so much, Dr. Nwachukwu. I know, it surely shows that you're very passionate about this topic. I just kind of was listening to you, and I'm glad you were able to clarify that this is not the same thing as hospice care. I was just wondering what the difference is. Let's say someone goes into the hospital and you already have a primary care that is already taking care of you, primary treatment team, like the providers and the team already managing you for this complexity already. So how is that different than palliative care? Is that a totally different service that you have to consult? And if you can clarify that, thank you.
Yes, so it's a special kind of service that needs to be consulted. They are called the specialist palliative care team. The primary team, mainly, they are disease focused. So what they do is their focus is to target the disease. But for the palliative care team, the focus is the patient as a person. The focus is, where do you want to go with this? It's a collaboration, actually. So the palliative care team, usually before they speak to the patients, they speak to the primary team. They also read about the patient on the charts. They try to understand the trajectory of this disease. Where is this disease going? At what stage is this patient in? And then they try to figure out the goals of care. What do we hope to achieve? But that is not a unilateral decision. They speak to the patient. They talk to the patient about the disease prognosis and where he or she is at this disease course. And then they speak to the patient in terms of, what are your goals? Are you someone who would want to, okay, this is where you are in this disease. You're having heart failure. Your ejection fraction is like 20. And then you don't want to get an implantable device because you feel it does not align with your goal of care. Okay, so what really matters to you at this point? Do you just want us to manage your symptoms? Is it that you don't just want to be breathless anymore? You just want to be able to breathe comfortably. You want to spend more time at home rather than frequently coming back with exacerbations of the heart failure, frequent hospitalizations. What really matters to you? What are your values? What are your preferences? What are your priorities? So the palliative care team is a specialist team that clarifies the goal of care. And then if the patient's goal of care is just relieve me of this distress, stop this breathing trouble, I want to be able to breathe better, then palliative care, again, gives medications, titrates the medication. They have that special training. They know the medications that work for certain symptoms, and they know when to escalate and when to de-escalate. The whole aim is to improve that patient's quality of life. Again, they provide additional layer of support. It's not just the physician, the social worker comes in, the chaplain comes in, the nurses come in. So they have that special training to help the patient and the families navigate. It's something that the primary care team cannot do. One is because they have lots of patients. They don't even have time to speak to the patient. They just have time to tell the patient, boom, 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 this is what's going on. This is how bad it is. Okay, bye. It's the palliative care that will take that time to speak to the patient and really know what the next steps should be. I hope that answers your question, Dr. Joey.
Thank you. Thank you for that.
So guys, if you have question on the first part, you can either put it in the comment section, the YouTube comment section, or if you want to ask your question, in the live streaming, then you need to enter the studio using the StreamYard link. Right now we have 10 people in the studio. So for the folks in the studio right now, Abiola, Yetunde, Oluwole, Oluwatosun Salako, Olu, Odion, if you guys don't have question, let me know so that if you have question, then let me know. I can bring you upstate to ask your question. But if you don't have any question, would you mind if I take you out so that anybody who has question can come in if they want to ask their question in the live session? We have a capacity of maximum of 10 for people who are in the studio. So just do us a favor. If you don't have questions, you can exit by yourself. And if you do have question and you want to ask it live, join the StreamYard link. So please only join the StreamYard link if you want to ask your question live. Thank you.
And I think what Nwachukwu, the speaker, is here, and why people are getting and warming up to ask questions. I know last time we connected, I know you were very passionate about this topic, and I know you went on and on. And I think also there's something about like maybe some fellowship applications, some awards that um, well, of course, I'm sure the speaker already, Dr. Aditola already read your bio, and I did see a lot of those awards that you won at the beginning. So, I think if I'm not mixing things up, you said something about pursuing, advancing in this world of palliative care.
Yes, most certainly. So it's a specialty that I'm very passionate about, and it's something that really does align with my personality. It's something that it's a field that I'm very sure it's it just aligns with me. It just aligns with me. It's I have that innate um I just gravitated naturally towards it. And the interesting thing is that back in 2018, 2019, the some of the publications that I did at that time, they were on quality of life. But even at that time when I did those publications, I didn't necessarily think about palliative care as a specialty, but it was something that I was always passionate about, advocating for quality of life, not just quantity. It's about quality of life. If I have years to live, I want to live them well. I don't want to have 100 years to live and I'm bedridden and I am demented and I have no clue who is around me or what's happening and I'm just suffering bedridden. I would like to spend those years knowing my family, speaking to them, knowing what's happening around. It's about quality of life. So even as at the time that I started advocating for quality of life, I hadn't really gotten so much exposure about palliative care. But then I started when I went into it and then I learned about it and I started seeing patients and how the palliative care takes care of the patients, I just knew that this is exactly where I need to be and this is where I want to be. So it's just that's why I feel like it's not I feel like I know it is something, a specialty that aligns with me.
It comes natural.
Yeah.
So, do you have more people with hands up? Because I have one more last question, but feel free if anybody else can bump me. Well, I think you're talking. We cannot hear you.
Yeah, for the folks in the studio, please put in the studio chats box if you have a question so I can bring you up stage.
Oh, okay. So in the meantime, while you're waiting, the quick question I was going to ask, I know, even as a physician, I did not, honestly, I thought I used to equate, hospice care and palliative, honestly, to be the same. But I'm glad you were able to kind of clarify today. The one question I was going to ask, how many centers do we have in the US? I'm not sure if you've done that study, that research. Do you have any idea of how many centers we have that have programs that tailored whether ACGME or non-ACGME that with this advanced training in palliative care, if possible?
Yes, I think there are about close to 200 in the United States. The last time I checked, there are close to about 200 centers that offer like specialized training fellowship in palliative care. There might, I mean, ACGME accredited ones. I'm not sure, I don't know about the others. But if you compare the number of centers that offer this specialist training, it's actually less than, a number of less than other, specialties. Let's take, for example, cardiovascular medicine or gastroenterology. So the number of centers that offer palliative care specialist training, they're actually fewer in number. And I'm just hoping that it's something that which I believe it's going to change with time. I believe that more centers are going to come up because it's really gaining a lot of ground. And even now, there are like subspecialties in the palliative care. You now have what we call neuropalliative care. So that is like special palliative care team that only deals with neurodegenerative diseases, Parkinson's disease, ALS, motor neuron disease, stroke. They just deal with neurocognitive problems. And then, other subspecialties are springing up, those that just deal with, let's say, gastrointestinal problems and things like that. So it's growing. It's growing and it's growing really rapidly. They have an annual meeting in America. The last one they had was in February. I went to Colorado for that meeting, and it was very exciting. It was amazing. Great people, great talk, great exposure. It was really good. It was really good. Yeah. And do we
Okay.
have more questions?
Any more questions for the folks in the studio? Please let me know if you want to ask a question live in the stream. We have 3 people in the studio. Do you have questions? And Cynthia Okoli says she has a question. So Cynthia, do you want to come in the studio or you want to ask your question in the comment section? I'm not getting a response. Dr. Nwachukwu, I think you can, let's go ahead. Oh, okay, 1 second.
Okay.
Somebody just, okay, I think Cynthia is here.
Great.
I believe. Let me bring her up. All right, unmute yourself, Cynthia. Go ahead.
Hi, sorry, I'm still trying to figure out how to use this. Okay, I have a question. Thank you, Dr. Shoma. Thank you for the teaching and all of that. I really appreciate the lessons and the insights on the difference between palliative and hospice. So my question is, right now we have a patient on floor. Can you all hear me?
Yeah.
Yes. Okay. So, this is she's 80 years old, and she and the family are already discussing plans of, like, she has end-stage renal disease and multi-organ failure. So it seems like we're not heading the direction of total recovery. So she's very like apathetic, weak, and all of that. No longer responding to treatment, and the family is already considering hospice, but they want to still do palliative first. And it seems like they already initially started the palliative, but today we were discussing with them because the son, who is the legal decision maker, is saying that he wants the mom to continue to be on dialysis, because he was advised in the past that if they discontinue dialysis, then the mom will have about like 5 6 days to live before she passed on. And he wants the mom to stay a little longer before leaving them. So, but this time around, she's always groaning in pain, and even though she's on like medication, she's on Norco, which is helping to control her pain. And then at this point, I wanted to know, like, considering that they are currently doing palliative. So if you have a patient that is on palliative, which like they're trying to, comfort care and all of that, but they are not looking at this patient passing on in the next 6 months, which like qualifies them for hospice. So at what point do they discontinue like the palliative care and have them move to hospice? Like, do you guys really do that, or is it that this kind of patients can continue to be under palliative care until they pass on, or is there a point under palliative care where you have to like invite hospice and have them continue the management of this patient? So how does it work? Like, at what point do you bring in hospice? Uh, can patient also continue with palliative till they pass on?
Right. So that's a very good question. And that's a question with so many aspects um, to be answered. So the son is the healthcare proxy, I believe.
That's correct.
But does the lady have the capacity to make decisions for herself?
No, she's Eno times one. Sometimes like she doesn't even know where she is. So the son
Okay.
makes all the decision.
Makes all the decisions. Okay.
Mm.
So that would have been my first place to start. If the patient is able to make their own decision, it's always easier because they are the ones in the situation. Like you said, she's groaning in pain. If she were able to make decisions for herself, that would have made things easier. Now, the son is the healthcare proxy. It is more difficult for the children to make decisions for their parents because, no one wants the parent to leave. Even if I've seen families that, you're just looking at this patient, this elderly lady, for example, looking not good, with a very poor quality of life. And the family is saying, no, we want her to be like that. She has a trach, she has a peg, she's always suffering from aspiration pneumonia, she's always coming in short of breath. She can't even feed. She has a peg tube, she's feeding through the belly. She is completely out. Quality of life, zero. But then the family still decides, yes, we want to keep her like that. In such situations, there's really nothing that you can do because you have to respect the family's wishes. They are the next in line to make decisions for the patient. And that is where one aspect that is very important comes in. Early goals of care. Let the patients make the decision while they are still able to. It is one of the major things that I advocate for. When you get into, as primary care physicians, for example, internists, for example, speak to the patient when they are still cognitive, when they are still able to make decisions for themselves. It saves a lot of trouble because you speak to them and then they'll tell you, for example, it doesn't have to be, but they'll say, when it gets to this stage that I am not cognitive and I'm in pain and I have a poor quality of life, this is what I want you to do for me. Just focus on my comfort. Stop all the unnecessary aggressive intervention. Stop the dialysis, for example, since it's no more helping. Stop this, and just focus on my comfort, and I'll just slowly transition. So it's always better to speak to the patient while they can still make their own decisions. But in this case now, it's not the case. So we've passed that stage. It's now the children making the decisions. Now, the thing is, palliative care, of course, 100% she qualifies for palliative care. Palliative care should definitely be involved in this woman's case. Not just because of the symptoms of pain, her pain needs to be better managed because pain is one of the major symptoms that nobody wants to live with. It just drops your quality of life like this. No one wants to be in pain. So palliative care should manage her pain better. If she needs to be on patient controlled analgesia, well, she may not be able to do that because her cognition is not quite where it should be. but her pain should be better controlled to improve her quality of life. So that is what palliative care will do. Now, when it comes to hospice, hospice is the care that happens when a patient has been prognosticated to have about 6 months or less to live. Now, the truth is that if she were to discontinue dialysis, there is a high possibility that she's going to pass within 6 months, and that qualifies her for hospice care. As far as I know, here in America, I think for you to go into hospice care, like complete hospice care, I think it is a recommendation that every active treatment has to stop. I think that's one of the criteria for someone to qualify to go into hospice care, because there are hospice benefits. So for you to get those benefits, you have to agree and sign, all those their forms and say that you're stopping this active treatment and you're just focusing on your comfort, and that qualifies you for hospice care. If the family insists on continuing dialysis, I don't think she's going to qualify for hospice, because the dialysis is a life sustaining, and if she continues on dialysis, if her only problem is the kidney, there's a high likelihood that she'll survive beyond 6 months. But if she were to stop the dialysis, there's a high likelihood she'll transition within 6 months. So for this family, I think it's going to be an ongoing goals of care discussion. One thing you have to keep in mind is that goals of care do not happen in one setting or in one sitting. No, it is something that is ongoing. It is something that you continue to do. So one step forward is that they have agreed to palliative care referral, and palliative care is involved in treating or managing this lady. So that is one step. By the time palliative care continues to manage her and continues to address her symptoms, the family themselves, it will get to the point when they see that, and they continue to have the goals of care discussion, because that is palliative care they have something we call consistent goals of care discussion and consistent symptom assessment. So they continue to check in with the family. They continue to support the family, because a good number of times when families say, I want everything to continue, just continue with the treatment, even when it's clear that the treatment is not going to lead to any meaningful recovery, they say continue the treatment, continue the treatment. It's because they haven't really had the time to interact with someone who really explains things to them. And one thing that I say to families like that, because I've met so many of them. One thing I say to them is, I tell them, take yourself away from this decision making. Think about your mom, not yourself. Look at your mom. Do you think that if she were to see herself in this situation, she would have preferred to continue living like this? Do you think this really aligns with what she would have wanted if she were cognitive enough to make a decision for herself? So, because one other thing that happens is that sometimes when families are making decisions, and maybe, for example, decision to stop dialysis, they feel like, oh my God, I'm killing my mom. If I say stop dialysis, that means I'm killing my mom. And then they have this guilt in them that, oh, I stopped the dialysis, that means I killed my mom or I killed my dad. But that's not what it is. When you explain to them and tell them to take themselves away and think about this lady who is groaning in pain every day, she wakes up in pain, she goes to bed in pain. She doesn't even know what's happening around her. All she is doing is fighting the pain. And then I ask them, if your mom were to make this decision, do you think she would have wanted to live like this? And it kind of gives them, sometimes, most times, they tend to reflect on that. And I tell them, you are making this decision on her behalf. You are her voice. You're not your voice. You are her voice. Because she's not able to speak now. You are speaking for her. And having known your mom for this length of time, what kind of person was she? What was life to her? Was she the kind of person that would hold on to a thread of life, whether or not her quality of life is good? Or was she the kind of person that would say, "Ah, when it gets to this point, please just stop. Just stop. If it's not helping me, just stop. I wouldn't want to be bedridden. I wouldn't want to continue, my blood continue being cycled because my kidneys are not working and I'm not really functional. I'm just in bed. I'm already in my 80s. I've done everything. I don't even recognize you. If I don't recognize you people anymore, then there is no need to continue." So help them find the voice of their parents rather than their own voice. Because as a child, your first instinct is, I don't want my mom to die. I don't want my dad to die. I'm going to do everything. I'm going to, if she codes 10 times, I'm going to resuscitate her 10 times. If she needs to live on the breathing machine, I'll keep her there. Let her just keep breathing. But that is suffering. That is suffering. And if you make them understand that at this point, you're really not helping her, you're hurting her. Sometimes it's good to, put your foot on the ground and really talk to them. And then a good number of times they come around and they really begin to reflect, are we really helping mom at this point? Or are we making her suffer? So, but it's not something that happens in one sitting. Palliative care keeps speaking, as they help with the pain, because what they want to do is to improve the quality of life for as long as possible. They help with the pain, they help with the symptoms, they continue supporting the family, and they continue having the goals of care discussion up until the point that the family would decide on hospice. Otherwise, you cannot force them to stop dialysis. You can't do that. They, at the end of the day, have to make their own decisions. What the palliative care team does is to help them navigate the complexity of those medical decisions. So I guess I'll stop there.
Yes, this was
Yeah.
super helpful. Thank you very much for explaining all of that. So I'm going to have a discussion tomorrow with the son, and I can tell you I'll be armed with a lot of information from him tomorrow. Thank you. I appreciate it. Thank you,
You're
Dr.
welcome.
Chioma.
You're welcome.
Awesome. Thanks for that detailed answer, Dr. Nwachukwu. Any other question from the folks in the studio and from audience in YouTube before we move to the next section of the presentation? Please indicate if you have question. Indicate in 3, 2, 1, or else we'll steam ahead. All right, I think we can go ahead, Dr. Nwachukwu.
Right. Okay. So the second part. Hold on. Oh, okay, there we go. Yeah, so this second part is I don't know. I think the thing I want to highlight, talking about the match, is to say that there is no one way. There is one goal, but there is no one way to achieving this goal. And, as you're applying for the match, you have expectation. You're going to prepare for the match. You're going to prepare for the application season, the cycle. You get your things ready. The preparation would entail, of course, networking with people. I am pro networking. Sometimes it looks like it's maybe you have that feeling that, oh my God, I'm disturbing this person. Disturb the person. One thing that my mom taught me at a very young age was, if you ask for something, there's a 50-50 chance. You either get it or you don't get it. But if you don't ask for that thing, it's 100% you're not getting it. So whenever I think about that, that stuck with me at a very young age. Whenever I think about that, I would say I'd rather ask. It's a 50-50, but I'll condition my mind that, okay, it's either I get it or I don't get it. But if I don't open my mouth to ask, then I will never get it. It's 100% nothing. So network, network, network. I'll tell you something. Before I got my a supervisor for my master's in Canada, I was in Nigeria at that time. I wrote emails to several people, many people. I wrote hundreds of emails, to be honest. Hundreds of emails I wrote to experts in Canada. I got like responses like, oh, we're not actually recruiting students right now. Oh, maybe next year we can think about it. Most of them did not even respond, but I kept on writing. I kept sending reminders. Whether it was bothering them or not, I don't know. But I just kept on sending reminders to those that I had not received responses from until they responded. So you're responding is either you say, no, I'm not able to take a student now, or you say, but I just needed a response to know where I am with you. And then eventually, when I got a supervisor who was able to give me scholarship and pay me stipends for my training, when I got to Canada, one day I was speaking with him and he said to me that the first time I sent him an email, he saw the email, but he decided not to respond. That he wanted to make sure I was really interested. And then when I sent a second reminder and the third reminder, he knew that I was really interested. And that was when he responded to me. So network, network, network. When they don't respond, give them like a few days and send them reminders again. Hey, this is me. I am this person. Oh, I did my medical school. I'm interested in internal medicine or family medicine or pediatrics in the States. And I would really love to connect with you to share more about myself and my interests. I'm very interested. Just write to the person again. They might see the first time and ignore you. For me, if I see it and I want to respond, I'll respond immediately. I don't have to wait for you to speak to me 10 times for me to respond. But it just happens like that, persistence. So as you're preparing for the application and you're getting your documents ready and you're getting things ready, like getting involved in some community service or some volunteerism or some research or some clinical work, engaging in conferences, for example, doing some kind of, just doing something clinically related or oriented. Network. I cannot overemphasize networking and the power of networking. So that is the first part. And then we go to the interviews. The interviews are, I don't know if I can speak as an expert in interviews because I haven't necessarily conducted, residency interviews. I've been part of residents that got to interact with candidates. And after the interaction, we were able to say, oh, I really like the confidence this one displayed. Oh, I think this one would be a good fit for our program. Yes, I've been able to do that, but from the level of the program directors and the program coordinators and the faculty, I may not be able to speak in that aspect. What I do know is that they like people who are personable. They like people who appear personable because sometimes it's very difficult for you to know someone who is personable by just speaking to the person over the camera. But you can actually guess that this person is somebody that I would like to work with just by the way this person is speaking to you and sounding sincere about their passion and who they really are, their personality. You can somehow tell. It's difficult, but you can actually somehow tell by just interacting with the person. So during the interviews, I would say appear personable, sound personable. I would say appear confident, speak like you should choose me. I'm actually going to be I'm actually going to be a great addition to your program. And this is why you should choose me. You know, some will say that there's a thin line between confidence and arrogance. Yes, don't be arrogant. Be confident, but appear confident. When you're speaking, speak like you know your stuff. Speak like you know yourself. Speak like you know that you're going to bring something to this program. Don't speak like you're begging. Um, I think I someone sent me their personal statement some time ago, and I read the personal statement. And the personal statement was good, but one thing that I felt was not that did not just sit right with me was that it sounded like the person was begging to be chosen. It sounded to me like the person was saying, "Oh, I've suffered a lot in my life, and please just take me, because this is really what is going to ease all the suffering that I've had to go through in my life," which is not. I don't think that's very okay. I mean, it's good to share personal stories, but your personal stories should also um, be strong enough to transition you, like to tell the reader that yes, you had to go through this stuff, but hey, I came out of it. I'm resilient enough. I conquered it, and this is where I am, and this is where I'm heading. These are my goals. And I think with my resilience and the kind of person I am, and having overcome all of this, I'm going to be a strong addition to your program. I'm bringing my emotional intelligence. I'm bringing my resilience. I'm bringing my determination to your program. You know, tell them what you're going to bring. Don't feel sorry when you're writing your personal statements. You know, share those stories, which can be very touching, but at the same time, let them know that, hey, this is me. And I am, if you get me, I'm a great catch for your program, things like that. So for the interview, when you're speaking, speak confidently. I think that was how I just deviated and talked about all of this, but speak confidently, appear confident. First impression is looking at you. This is my first impression about you. So take the way you look that day very seriously. Okay. Take your dressing, your everything very seriously. You may think they don't matter, but if you don't dress well, it's easier to pick you out that you did not dress well. If you do dress well, you might say, "Oh, a lot of us are going to dress well." So they may not notice if everyone dresses well. But if you don't, at least they know that they're going to, take you out that you did not dress well. So take the time and dress well for your interviews and appear confident for the interviews. I feel like a lot of things, you've heard a lot about the application process, the do's, the don'ts. And really, I don't think there's anything I'm going to say that you have not heard. And that's why I just wanted to touch another aspect of of this whole process. So let's say you do your preparation, crossed all the T's, dotted all the I's, you went for your interview, and now you're waiting for the match. Under normal circumstances, ideally, in a perfect world, what we expect is that all of us are going to match. All of us are going to match. We transition to residency. In this cycle, everyone that applies is going to match. But in reality, is that really true? It's possible. Everyone can match in this, like in Joey IMG group, everyone can match. But I don't think all the applicants all over would be able to match, because there are very limited spots and there are thousands of people applying. And I don't think that all of them can match in one cycle. And that brings me to what if? What if? And that is where it's that you have to really think about something we call the hope and worry phrase. It's something that is frequently used in palliative care. Let's say, for example, I really do hope that everybody in this Joey IMG to IMG group matches in the next cycle. That is my hope. That is my prayer. That is what I really, really hope for. But I worry that that might not be the case. So this is just a reality check that as much as I really hope that everyone matches, let's go back to the word. As much as I really hope that your mom recovers from this advanced cancer that has metastasized to her brain and to all of her body, as much as I hope that she recovers, I worry that she may not recover. I worry that she may have a very limited time to live. So this is just an example. And that brings me to what? Your plan B. I applied twice. The first time I applied to residency, I matched. But I didn't start residency at that time because of personal issues that I had. So I couldn't start at that time. It's a story for another day, a very long story. I deferred my match the second time, or I deferred it the first time. So I matched the first time, but I couldn't start. The program was kind enough to defer my match. And then when it got to that year, I couldn't start again. I couldn't start as well. So I missed the opportunity twice. So what happened then? I was hoping to match, and yes, I matched, but then I didn't start the residency. But even before I applied for residency match, I had a plan B. I have always been someone that, sets a goal and gets it. Like things work. Once I set my eye on this, or I set my mind to get this, it just works. It just clicks. The very first major setback that I had was when I matched but could not start my residency. So it hit me very hard, so hard, like it would hit anyone. It hit me so hard. And it took me quite some time to get out of that, that very unhappy place. Can imagine having worked and done all the work and you matched actually, and you're just unable to start the program because of some reason. So after that happened, I think it was around that time that I went into academics. But the plan B I had was, I said to myself, I have to move forward. I have to advance. If I'm not able to start this clinical, I need to get my master's at least, get an additional degree. I need to enhance myself. So that was my plan B. So when it didn't happen the second time, I was already into academics at that time. When it didn't happen the second time, I just said, okay, now I have to take this really seriously. And that was when I started applying to Canadian schools, because I had already made up my mind it's going to be Canada. I mean, there are people have different things. That's why I say just have a plan B. People have different things. Different. For me at that time, I just said it has to be Canada. I didn't apply to any UK school. I didn't apply to any other country. It was just Canada I applied to. And thankfully, I got a spot in Canada and I went on to do that master's. And I tell you, if I were to list 3 things that I would say are very pivotal in my life now, doing that master's in Canada would be one of them. Why? It's opened a lot of doors for me. I have connections in Canada now that I would not have had, because there's nothing in this world that have made me have those connections in Canada. It's a place now that I go to and I know that I have people that I just met. It's not like they're family, friends and colleagues that I met on that journey. I have people that I can call up and request for things, and they're like, of course, I will do this for you. Of course, it's not a problem at all. And then during my journey as a master's student, I took it seriously. I didn't let, the sadness of not being able to match twice after my USMLE, I didn't let it interfere in my master's program. I took it very seriously, and it was very challenging because the master's was in neuroscience. I had to do with a lot of micro dissections, a lot of recording from nerves, things that I had never seen and done in my life. That was the first time that I started doing them, but I took that very seriously. And it all paid off at the end of the day with those awards, with those recognitions. I didn't think that I would get as many awards from Canada, just being a student there. So it's when you have a plan, your main plan is the USMLE, is the match. That is your plan. And you're really hoping that this is going to click. I'm going to match in this next cycle. And that is what we are praying for. That is what we are hoping for. That is what I am rooting for you, 100%. But what I'm trying to say is that have a plan B. Just in case it doesn't happen as quickly as you had hoped. What is your second plan? Have a plan B, have a plan C, because even while I was doing my master's, I had already said to myself, okay, I'm going to apply again. But I thought to myself, okay, what if it doesn't click again? What am I going to do? I said to myself, if it doesn't click, I'm going to start doing Canadian medical licensing exam. I already had a plan C. And interestingly, my supervisor thought I was so good with the research that he voluntarily offered me a position in his lab. So already I had a job waiting for me. Even when I told him that, okay, I'm rounding off my master's, this is my plan, I'm going to apply to match the US program. He said to me that day, which was very funny, he said to me, oh, wow, that's really good. But what if it doesn't work? So I said to him, well, I'll look for a job. And then he told me, yeah, the reason I'm asking is because I want you to come work for me. You can be a research assistant, and I'm already submitting, the budget for the next year. I just want to know if you're interested so I can include your name. So I already had a job. So I already had like plan C, but my other plan was, even while I'm working as a research assistant, I'm going to start writing Canadian medical exams and see if I can match in a Canadian residency program. So as much as I really hoped that the USMLE match would work, I had plan C and plan D in place. But the good thing was the first plan later, it worked. So the third time I applied, I was able to match and I was able to start my residency. But what I'm just trying to say in all of this is you can have a plan A. What you hope is that you just move straight on and then you get it. Bam, successful, which is great. Many people, their lives are like this. And to be frank with you, my life was like this until the first thing hit me hard when I matched and I didn't start the residency. But most people, and the reality of life is that sometimes it doesn't, or a good number of times it doesn't happen that way. You have a plan A, and then you have to go through all the rigors of life. It's not a straight path. You have to struggle, you have to study, you have to network, you have to write a personal statement over and over again, send it to people, all of these rigors and rigors and rigors. And maybe you match, great. Maybe you don't match. What next? You don't just leave it there. You don't feel helpless. It's good to, acknowledge emotions. It's good to let your emotions flow. I was very emotional those 2 times I did not match. Very, very emotional. But I don't know how it just happened that one day I just woke up and I was like, what are you doing? What are you doing? So what now? You just want to stay here and, just feel sorry for yourself? This is not you. And then just like that, I just got up and just moved on with my life and moved on with the plan that I had already had. So have a plan B. If it's possible, have a C and D. But hope that the first plan that you have, which is to get into the match, works out. And I do hope that it works out. So my take home, or what I want you to take home today is, or are, that your journey would look like anyone else's. No two journeys are the same. They might be similar, but not exactly the same. And that is your story. That is your strength. Success is not, rigidly following a predetermined route. For me, your idea might be different, but for me, success is resilience. Success is determination. Success is focus. You have to have that focus. You have to be determined. You have to be resilient. And you have to be wise enough to know that that first plan may not work. You have to be wise enough to know that life could happen and it could shift beneath your feet. And you just have to have a backup plan. Okay? If the plan A doesn't work, it doesn't mean that that dream is lost. No, you dreamt it. It's in your head, it's in your mind. You dreamt it. So if the first path you took did not work and you did not match, for example, it doesn't mean you've lost out. It doesn't mean it's the end. It means you have to get up again and recalibrate. Go back to the drawing board. Go back to that plan B that you had. And you have to move ahead with that plan. If you need to get to plan D, move ahead with that plan. Because you have one goal, you have one destination, and it's your job to get to that destination as long as you still have breath in you. So every setback or any unexpected turn is just a part of your story. I just told you my story. I mean, there are several parts to it, but I just told you it is my story. I'm even thinking of writing a book about it sometime in my life. So it's my story. So whatever unexpected turn, whatever detour, whatever drift that you face, it just forms part of your story. And then you tell your story, and it just shows how resilient you are. It's a test of your commitment. And if you're able to get through it and still move on and still come out tops, then that makes your story even more interesting. So keep moving. Your persistence will determine the end of that story. And remember that the only way you fail, really, is if you stop trying. So keep trying, keep moving, be resilient, be determined, focus on that story, focus on that destination, and you will definitely reach that destination. I think that's all I have, and I'll be happy to take any questions about the match, any comments at all.
Wow, wow, wow. Thank you, Dr. Nwachukwu. Those were powerful punches. Awesome, awesome. Yeah, I have there's a question in the chat from Dr. Kamal. It says, when sending an initial email to express interest in a program, is it okay to just write about your interest in their program, or is it better to also attach your CV/personal statement?
Okay, so anyway, full disclosure, I'm applying for fellowship. So all of us are actually applying for something at this point. So for the programs where I sent an email to indicate interest, I think I did attach my CV. So the thing is that where this is different for me is that I started indicating interest long before this application season. I started indicating interest as far back as 4 months ago, maybe 3 months ago. I started indicating interest. That was when I started really networking with people. And I attached my CV when I indicated interest. But now sending them a reminder, I don't attach my CV there because I'm like, the application season is here already. Well, my CV is going to be there. I just give them like a little blurb about myself, tell them that I schooled in Nigeria and I have a master's degree and I'm passionate about this because of this. I just give them the highlights. Some people would say attach your CV. I don't think there's a right or wrong answer, really. I don't think there's a right or wrong answer. For me, the first time I indicated interest, I attached my CV because I felt it was quite early and someone would have the time to open my CV and look at it. But then within this application season that I'm writing again to reintroduce myself, I didn't put my CV there because I feel they wouldn't even have the time to look at my CV. Some people might still have the time, but I feel like I just feel like program directors are quite busy at this point that they don't really open up things that they don't have to open up. But if you're trying to network with maybe a resident who is in the program, or maybe just a physician, a faculty member that is in the program, of course I will attach my CV because I feel like they have more time on their hands and they might be able to open up my CV. So I don't think there's a right or wrong answer. Just whatever your mind tells you to do, it
Do
just
it
might
well.
work out. Yeah, do it well.
Thank you, Dr. Nwachukwu. Any other questions from our YouTube audience? If you have questions again for folks on YouTube, put it in the comment section. I can read it out for you. And if you want to ask a question live in the stream, just join the StreamYard link. I have some people in the StreamYard. I'm sorry, I'm going to call you guys then because you guys are in the studio. And if you're in the studio, then you either have a question or you have comments. Ekanem Chukwuba Oladuni Akimbolade. Do you guys have questions? I see you guys in the studio. Jack Shack, you're also in here. Any question?
Guys, come on, questions. Questions, comments, clarifications, concerns, anything, thoughts.
Any question, guys? Or our seniors in the house, we have 65 people watching on the live. If we have any seniors who wants to add a comment, want to throw in one or two comments, please. Oh, Chukuma has a question. Let me bring him
Go for it.
Up.
Hello, good afternoon.
Hi.
Good evening. Thank you for all that you've taught us today. It was really encouraging. For some of us, we are at the point where when we listen to some people, you say, okay, well, let me see, try again. So for my own case, let me just paint a picture so that I'll see what your advice would be. I think I've done potentially all I need to do. I've networked. I'm an old graduate, graduated in 1999. I did residency in Nigeria pediatrics, and I did the first match. I didn't get it. I had only one interview. Then the second one was this last one. I had three, and I thought I was almost there because I had people inside that helped me get those interviews. I didn't went for second look, and still when the result came out, it didn't go well. And at that point, I was like, no, I'm not gonna try again. I'm even getting old, so I have so many things against me: your graduation age and all that. So if you're in my position, I heard everything you said, and because of that, I'm encouraged to do the same application cycle. I think I've done most things I need to do. People have reviewed my personal statements, my CV, course, each time before I submit, people go through, so, okay, dot the T's, cross the I's, and dot the I's and cross the T's. So if you're in my position, you're old graduates, age, you're above 50, and all that. What do you think one can still do at this point to help?
Okay, so at the time I was reapplying, I'm just going to circle back to my story. I didn't graduate in the 90s, but at the time I was applying, I very well qualified as an old graduate. I even felt old applying at that time. But there was one thing that one program coordinator said to me that time. She said, as long as that, yes, people talk about old graduates and old graduates, but that really what they look out for is what have you been doing since then? Have you just been at home or have you been applying yourself clinically? Have you been in the clinical space? Academics is okay, but she told me that really what they're focusing is, have you been doing something clinical? Have you been involved clinically? That tells them that you still have the skills and you've not lost the skills. Because if you haven't been, she said to me, if I haven't been applying myself to the clinical world, that it's assumed that I've lost touch and I'm no more, clinically inclined and I don't have the skills anymore. And it will be very difficult for me to, get back into that space. So she said to me, as much as possible, yeah, that they don't know whether or not I'm still going to get in or not, but that I should remain in that clinical space. That whether I'm an old graduate or not, as long as I can still show them that I'm still in line with or in touch with clinicals, that would be my advantage. There was another resident. This was a resident. This was the program director that said this to me. The other person that I spoke to at that time was a resident in a very good program. And she said to me that interestingly, her own program actually looks for older people. That they feel that her current program director actually feels that the younger ones are restless. They complain a lot. They are less resilient. Their tolerance level is very low. So that actually she looks for mature people, because I was speaking
Please, what's the name
to
of the program?
so I was speaking to that resident at that time, and she told me the program director actually looks for mature people, and that in her set, that all of them are actually very mature people, because we graduated the same year, but she got in. She didn't get in immediately. She also like went to UK, did stuff in UK, and then eventually she then did the USMLE. So she was also like old graduate at that time. So I think it's, as long as you've done things you're supposed to do or things that are expected of you to do, and you have been in that clinical space and you network, the power of networking. I thought it was only, sometimes in Nigeria we say I don't know, but it's not, I'm saying that it's not even an I am thing, it's a networking thing. This world right now is all about networking. You have to know your onion, like you have to have your skills, but networking is also as powerful as those skills. And if you have both, then you're good to go. So I would say network as much as you can, keep networking, don't give up. I think you have the dream and you're a doctor and this is your dream. I don't think you should let go. I think you should um, have plans. I think you should have other things that you can fall back to and things that you're doing while you're waiting for this one to click, so that you don't just, focus and put all your eggs in one basket and you're hoping that this is until it happens. I'm not going to do anything else, which I believe, of course, I believe you're doing other things. But while you're at it, you know, network with people, just keep networking with people, keep being in that clinical space, keep improving yourself, improving your CV so that it's not the same CV that you used to apply 5 years ago or 3 years ago that you're presenting to them again after 3 years and they're like, okay, so we're still where we are. Okay, so okay, what have you got? So at that time when I didn't match, at least the other time that I applied with a master's, I applied with awards, I applied with projects, there are more things that I added on to my application. So it was not the same application. So although I was, yes, an old graduate, but I had things to show them. This is how far I've grown since that last time that we spoke. And this is what I'm presenting to you now. I'm even a better person than that time that you considered my application. So I think the long and short of this is that like we said, don't give up. It doesn't have to be a straight path. It can be that way, that way, that way. But also have other plans and hope for the best.
He has a he has a follow-up question in the chat. Do you want to ask or you want me to read out, Dr. Nwachukwu?
Okay, thank you for the response. I'm grateful. So I wanted to add on, like getting the New York limited license permit to work there. Is it going to be helpful or hurtful? Thank you.
Honestly, I do not know. I do not know if that will help or if that would hurt. I really do not have the capacity to comment on that. I don't know. Sorry.
Okay, thank you.
Any comment from any of the seniors, either in addition to Dr. Nwachukwu's response or for Dr. Nwachukwu's question? Well, Dr. Nwachukwu, with regards to your second question, from what I have heard, all the people that I know who have gotten the New York limited license said it was a game changer for them. So I'm not sure. Maybe there are some people who worked in New York with a limited license and did not match. I don't know. But the people that I know who went through that route are all in residency now, and they all have one thing in common to say. It helped them because what it does is that it puts them right back in the center of patient care. And you're not, and they say it's even a better option than externship because right now you're actually responsible for patient care. You are in the forefront of patient care. It's just that the setting was different. You probably most likely be working in a nursing home or a clinic setting, but at least you are the one seeing the patient, as compared to externship where what you can do is limited. And with a New York limited license, you can also get an MPI number. So to answer that question, from my understanding, based off what I've heard and the people that I know, it helps. Does it guarantee residency? Of course, I don't think so. It doesn't guarantee residency, but for older graduates, they told it helped because it helped them, so I assume it helps.
Okay, thank you.
You're welcome. Any other questions? Somebody said they had a comment. Mom Michi, have you found the link? Or you want to type your comment in the chat box?
I guess I can stop sharing.
It says full. Oh, okay. Okay, so 1 second. I'm going to have to kick someone out. Oladone, Ogo, Chioma, Olani, you guys are in the studio. Do you have question or comment? Laura, do you have question or comment? Please indicate in the chat box so I can bring you up stage. There's someone on the Mom Michi says she wants to talk, but the studio is full. But we have a maximum capacity of 10. We're already 10 in the studio. So, and my comment is not typable. Yeah, she said her comment is not typable. So please, if you don't have question, can you exit the studio so that she can come in? Please. And if you have questions, just let me know, indicate in the chat so I can bring you up, because as you guys are in the studio now, there's nothing you will say that will be heard. I need to bring you up on the stage. So Dr. Chukwu, Ibuka, Dr. Laura, or Dr. Lani Oladuni, do you have questions or comments so I can bring you up? Oh, that's Dr. Laura. Well, let me bring you up then. I'm going to add you to the stage. Dr. Laura is Mom Michi. You are in already. Since your devices is not connected, can you refresh your laptop or something? I'm trying to bring you up the stage, but it says your device is not connected. While you do that, Chukwu Ebuka, do you have questions or comments? Please. Oladoni, do you have questions or comments? Okay, Dr. Laura, can you refresh, please? Dr. Nwachukwu, I don't know if you can see her chat. She said her comment is about the old grad. You can reach out privately. That's Dr. Laura. So I don't know how you can get her number. Please, can you differentiate? Okay, so Chukwu Ebuka is asking, can you differentiate between externship and observership?
I think externship is more hands-on. I think here observership is like you're not really interacting with the patients, you're not really touching the patients, you're just observing. I think externship is more of a hands-on clinical experience where you speak to the patient, you can take history, you can examine the patients. Yeah, that's what I think is the difference. I may be wrong, but last time I checked, I think that's the difference. I don't know what the seniors think. Yeah.
Where are our seniors in the house? Please, we need you. I have typed plenty. Nobody's responding to me. Dr. Laura, can you please go back in? It says your mic and your video is not connected. That's why I'm unable to bring you up stage. When you click on the StreamYard link, before you enter the stage, you will see an option to unmute yourself and also enable your video. Even if you don't want to enable your video, at least we need that mic to be on. Then you can proceed to enter the stage, enter the studio. Because yeah, that's the only reason why I'm unable to bring you up. Can you try that again? Even me, I want to hear your comment because me too, I'm an old graduate. So I'm eager to hear what advice you want to give us because I'm also a dinosaur. Okay, that's the Nwachukwu. Olani, do you have a question or comments? You are in the studio. And I just brought you upstage. You are on the live scene now. Any other seniors in the house, please? How do I get in touch with Mom Richie on YouTube? Mom Richie, would you mind getting in touch with me or any of the coordinators with your phone number so I can pass it on to Dr. Nwachukwu? Or even if it's Dr. Joey, so they can give it to Dr. Nwachukwu. Because I wouldn't say you should put your phone number on the live YouTube comment section. Any other comments? Okay, looks like no more comment. Unfortunately, we still haven't been able to add Dr. Laura here. So I hope she will reach out to me or the coordinators or Dr. Joy, and then Dr. Nwachukwu, you can get a number from there. So it's 6 minutes to 8. We'll still have 6 more minutes to go, or if there's no more comment, then I think we may call it a night. Thank you so much, Dr. Nwachukwu, for your time.
Thank you for having me.
This has been very insightful. Yeah, you gave a different perspective and, to what we all thought about palliative care and hospice. And this is my first time actually hearing this aspects, and to even know that there's something like that, which is when we hear palliative care, the first thing that comes to our mind is hospice. So this is very, very insightful. And also, not sure why I'm not able to make a comment. No, we're trying to bring you in, like on stage. Did you click on the, I think she's in the studio. You're in the studio now. Yeah. Again, it's saying that you need to connect your mic before I can add you to the stream. That's what it's telling me, that your mic is not connected. I'm so sorry. It's saying you need to connect your mic. Can you put in the chat section? Did you connect your mic on mute? Please, the old IMG should reach out to me. And we are plenty that reach out to you because I'm an old IMG. It's not only him. So, yeah, that's a lot. I don't know what's going on. Oh, okay, pediatrics. Okay. Yeah, so Dr. Laura, then you can reach out to myself or reach out to him directly. His name is Nwachukwu Chukwuma on the WhatsApp group. Because I wouldn't say you should put your phone number here. But for some reason, we cannot bring you up. Your phone is not connected for some reason. I don't know why. All right. Any other comments from any seniors or questions? And thank you guys for accommodating the little lapses here and there. This is our first time doing a YouTube stream. I think it's going to get better as we proceed. And thanks, Dr. Grace Okoro, for helping pioneer this. Dr. Nwachukwu can make a comment on WhatsApp now. Okay, yeah, Dr. Nwachukwu, why don't you put a comment in the WhatsApp group so that, and indicate that you are the one who asks about, you are the experienced IMG. They say we should not call ourselves old IMG. You are the experienced IMG who is asking about pediatrics so that she can reach out to you directly. Why don't you do that, Dr. Nwachukwu? Dr. Joey, you are on the stage. You have something to say? All right, I think we can. Any final words? Any parting shots, Dr. Nwachukwu, before we call it a night?
I guess the last thing I said, that the only way you fail is if you stop trying. So as long as you're trying, you're doing something. And I wish everyone all the best in the forthcoming match.
Thank you. Thank you very much. Thanks, everyone. I see one comment before I shut down. All right, yeah, guys, put in your clap emoji, love emoji, and everything. Anyway, you want to appreciate Dr. Nwachukwu, please put it in the comment section, put it in the main chat in Telegram, for spending a night with us and enlightening us about supportive care. I think that was very insightful, and also her tidbits with regards to approaching the match. Thank you very much, Dr. Nwachukwu. We appreciate your time.
Thank you so
Thanks
much.
everyone for joining us tonight. We'll meet again same time next week. Now we are live, and we're gonna be. This is the route we're going now. So, yeah, thank you. Have a good rest of your weekend, guys.
Have a good weekend.
Thank you.